Hello everyone. Myself Dr. Praveen Kumar Pathak. I work as a professor at the Center for the Study of Regional Development in Jawaharlal Nehru University. So today, as part of the MOOCs course on the geography of health, I am going to discuss with you an important issue which is entitled Understanding the Interactions of Food and Nutrition with the Disease Burden. Now, when we were discussing in previous sessions that how geography of health tries to understand the spatial patterning of health behaviors, health outcomes, health system performance, and how that is related with different social determinants of health and environmental drivers of health outcomes. In the series of these events, the dietary pattern and the food habits of the population has been studied by geographers and other epidemiologists over the years to understand to what an extent food consumption patterns has any association with the burden of disease in any population. Now, if you look from theoretical perspective, any society that experiences demographic transition, which is basically shift in the vital rates from higher equilibrium to the lower equilibrium, is basically associated with changes in the socioeconomic circumstances of any society, which means that as any society transfer itself from an agrarian, rural, pre-modern society to an industrial, post-modern society, there are numerous changes which happens in the society and the characteristics of the population. For example, if you look at the standard of living of the population, it increases as people move from agriculture to industrial production. With this improvement in the saving and the standard of living of people, these additional resources are then invested into areas of human capital formation, which includes education. Access to quality education allows improvement in the skill building of the population. And these important elements of development ultimately has direct bearing on the health status and changes in the lifestyle of population. Along with demographic changes, these transitions are also accompanied by something called epidemiological transition. This term, which was used by Abdel Omuran in 1971, with an idea to demarcate how there is a gradual shift in the pattern of diseases in a population with declining level of mortality. So imagine in traditional society, Omuran argues that population tend to suffer from varieties of issues related to infectious and communicable diseases, and most of the death in these stages are clustered in the younger or early ages of the population. But as the process of development unfold with improvement in the standard of living and lifestyle of people, similarly the pattern of diseases also undergoes very drastic change, and it has been observed in several developed societies that the burden of disease shifts from infectious and communicable diseases to chronic and degenerative diseases. This also involves change in the age pattern of mortality, wherein in the developed society or advanced industrial society, now most of the deaths are now taking place at advanced ages, because as I discussed, there is an average improvement in the health status of society, and the life expectancy in several of these societies is fairly high. I mean, more than 80 years on an average at the time of birth. So with these changes, we observe that development is associated with the changing burden of diseases that we observe in any society. So as demographic changes is followed with epidemiological transition, we observe that there is a characteristics variation in terms of the burden of disease in the developed versus developing countries. So most of the developed and advanced countries where the age structure of population has changed, where life expectancy is high. So now if you look at the concentration of mortality is gradually concentrated at higher ages. Now, because of these higher life expectancy and higher age survival, at the end of the day everybody has to die. But if you look at the clustering of death at higher ages, it means that these additional years of life people are grappling with numerous chronic and lifestyle ailments, including issues related with epidemics of heart strokes. People are suffering from high blood pressure, hypertensions. So all these important health issues, they come up because there is a drastic change in the age composition of population, and likewise changes in the concentration of diseases. So in the Western context or in the industrial world context, we observe that large proportion of population is suffering from degenerative, chronic and lifestyle diseases. And why it is important? Because from the policy perspective, it is extremely crucial for planners and government to know what is the burden of disease. Because if we have limited idea of the burden of diseases, it may not be possible to plan for health systems response with regard to the demand in the population. And likewise, linkages between these demographic changes are also associated with the nutritional habits or dietary patterns in the population. And studies have shown, particularly Popkin and others have found that along with demographic transition, there is also something called nutritional transition, which essentially means a characteristic shift in the pattern of diseases which are related to the dietary habit or the nutritional consumption patterns in the population. And as I was discussing with you shortly, that how epidemiological transition happens from underdeveloped society to developed society, where the pattern of disease moves from infectious and communicable to lifestyle diseases, degenerative diseases. And likewise, these communicable diseases or infectious diseases are also related with the dietary pattern that is observed in population. Empirical data in various countries have clearly shown that non-communicable diseases or NCDs, for instance diabetes or cardiovascular diseases, stroke, high blood pressure, cancer, etc., is very much related, among other things, with the dietary pattern in the population. Several studies have also found important factors which may be associated with pattern or burden of diseases. People talk about changes in the behavioral pattern in the population. How active or sedentary lifestyle that people are adhering has the direct bearing with health outcomes or burden of diseases. Numerous studies have found that in case of urban societies or Western society, developed society, where population fairly limited number of population are engaged in active living or physically active life, they have relatively lower burden of diseases. Likewise, if you look at diet is an extremely important risk factor which has a direct bearing with the burden of diseases in any population. And if you look at the dietary patterns, there have been numbers of global and regional analysis, and they have tried to look at how consumption of healthy food has direct bearing with reduced burden of diseases, vis-a-vis if there is a large chunk of the population that consumes food that is classified as unhealthy, that also has a direct bearing with numerous health and nutritional outcomes that will be discussed in few minutes from now. And so there are also sections of population which is indulging into substance abuse, including smoking and alcohol consumption. And numbers of studies in the Western context and also in the context of Global South have clearly shown that disproportionate consumption of substances abuse, including alcohol or smoking, has been associated with numerous non-communicable diseases. And so therefore these are important risk factors which geographers, social scientists, health planners, epidemiologists routinely analyze. They try to measure how these risk factors are concentrated at this national level and subnational level for appropriate planning and program implementation. Now if you look at this graph, which tells you the global story of how the burden of disease has actually transformed in the last 7 decades at the global level, you clearly see that the area which is marked with dark blue color is essentially related with non-communicable diseases, and how over time, due to non-communicable diseases, the burden of disease has shifted from infectious and communicable to non-communicable disease. If you compare in 1950s and 60s, you see that there was largely equal proportion of burden of disease related with communicable and non-communicable diseases. But as the process of development has unfolded, which means that there has been tremendous change in the places where people are living. So back in 50s, majority of these people were largely living in the rural areas or smaller cities and towns. And gradually with the wave of urbanization due to industrialization, a lot of these people are now moving to cities and urban life, so which has its own implications. So when you talk about urban living, you are presented with number of risk factor. For example, open space, green spaces. So these spaces are relatively limited as compared to the countryside or rural areas where people have large open spaces, very different lifestyle, the occupational pattern are very different. So therefore, as the world is becoming more urban, we are presented with number of non-communicable diseases, chronic diseases, which is rising. And likewise, the world has been able to very much control on infectious and communicable diseases, particularly with advancement of quality immunization care in different parts of the world. And the third section is, of course, injuries, which over the years has remained by and large the same. But if you compare how the burden of diseases varies in different different regions of the world, it's very interesting to see, on the top left part of this graph, where you see that among the low income countries, it's predominantly over the last 7 decades that people are suffering largely from infectious and communicable diseases. Whereas the share of burden of disease from the non-communicable diseases has been by and large relatively smaller. So, it's like 2/3 of the population in the low middle income countries is still struggling to survive from the risk of infectious and communicable disease. On the contrary, if you look at the advanced economies, the so-called developed countries, we see that more than 70 to 80% of the population in the last 7 to 8 decades is actually grappling from the challenges due to increasing burden of disease related with NCDs, non-communicable diseases, degenerative diseases, chronic diseases. And the point I want to put across here is that many of these NCDs, as I counted before, are related to dietary patterns which is observed in the population, physical activities that people are engaged into, substance abuses that people are engaged into, what kind of lifestyle that people are adhering to. So all these are important risk factors that predict the burden of diseases in the advanced society. And of course, one should also be mindful of the fact that the age composition is extremely different in the Western society, which has already has gone through demographic transition. It's the final stage, and by and large the age structure of population is older. So there is a compression and clustering of NCDs and burden of diseases in the advanced society. So if we have to see how the world, particularly global south, can manage from the experiences of the advanced society, it is a high time for us to know what are the important risk factors for countries like India. Now, India is also a very large and diverse country in terms of its demographic size, in terms of its socioeconomic development, achievements and potential, and also in terms of the resources which are invested in human capital formation, including the sector of health. At the global level, this is another important data which shows how the disease-adjusted life lost, year lost to various kind of disabilities. We clearly see that it's basically the global south, countries from Africa, Asia, particularly Southern Asia, where there is a disproportionate clustering of the non-communicable diseases. Now, if we have to understand what is the interaction between availability of food or nutrition and how that is related to human development outcomes. So there is a very interesting study which I am presenting here. You can so this study basically talks about, this framework basically talks about how areas which are impoverished, areas which are under development, how the restriction of nutritional supply to the population has implications of poor human development. So what is happening? Look at a context of a country where, say for example, development status is still very very backward or lagging behind. So what happens if the state is economically poor or not well governed, or social development parameters are poor. So what does it mean? That large proportion of population has lower income. If they have lower income, they have lower saving, and thus they have limited investment on food consumption or healthy food or access to healthcare services. So all these means that at the aggregate national level, there will be a scenario of food insecurity. So if at the aggregate level you have food insecurity scenario, which may further be complicated or compounded with environmental hazards. So for example, if the population in the underdeveloped world or areas which are facing resource crunch, they also face numerous environmental hazards. There is either there is lack of supply of potable drinking water or sanitation services. There could also be problem with regard to land management, proper use of land for agriculture purposes. There could also be problem related to air pollution. So on the one hand, you have problem on development deficit. On the other hand, we have a problem on the hand of environmental hazards. These two together further enhances the insecurity related with food and food security in several of these impoverished and resource poor setting. Now what happens? So if at the national or a state or society level, we are already facing resource crunch and there is a food insecurity scenario, it will have a bearing on household level food insecurities, which means that if you talk about children, if you talk about women, or if you talk about adults, each one of them will have lower access to healthy and nutritious food. What does it mean? It means that suppose if there is a woman who has become pregnant, so there is a likelihood that due to limited supply of nutritious food, it will have a bearing on the growth, intrauterine growth of the fetus, which in the long term will mean that many of women who live in low and middle income countries globally, it has been observed that many of them are not able to successfully complete their pregnancy term, and you have a lot of burden, disproportionate burden of preterm birth, which means that the fetus has not survived its complete term and delivered premature birth, which is also linked with low birth weights. And due to low birth weight, there are a number of infants who are not able to survive, and so therefore many of these low and middle income countries from South Asia and Africa, they continue to suffer disproportionate burden of neonatal mortality, infant mortality and child mortality. So, and along with this, not only during the lack of supply of nutritious food to the women in her pregnancy, but even after delivery, suppose there is an infant, if he or she is not properly breastfed or exclusively breastfed for 6 months, it has again implications on the cognitive skill development among young infants in the population. It means that suppose in the first 1,000 days of life, if the infants are not taken care of in terms of proper nutrition, one of the best source of nutrition in the global south is 6 months exclusive breastfeeding. And so then what happens is many of these infants ended up facing number of health issues. For example, diarrheal diseases takes a huge toll on the health and well-being of infants in global south. Along with that, number of children also face cognitive retardation. Basically, the opportunity of cognitive development reduces if the nutrition supply is not taken care of. And there are a number of other studies from global south and elsewhere which shows that if the nutrition supply or if there is a lack of nutritional supply in the intrauterine phase, it has a bearing on the long-term health implication of the population, which means that if a child or infant during the initial phase of life was not properly fed, was not properly provided nutritious food, then he or she has on an average higher risk of grappling various kind of non-communicable diseases. And so therefore this is a kind of cycle which has a long-term implication. So therefore the message from this framework is simple, that if we have to break this vicious cycle of nutritional deprivation across generation, it is extremely important that the efforts must be concerted at various policy level, starting from the top national level, then subnational level, then at the household level and community level. Then only we can probably help to improve the nutritional status of mothers, pregnant mothers and children, which by and large accounts for disproportionate burden of diseases in the global south, particularly in the low and middle income country of the world. Now, if you look at how these nutritional environment and health risks are associated, numbers of studies which are available, they point that the initial fetal development phase is a phase of life where there is a huge requirement of energy through nutrition, both for the pregnant women and also for the growth of the fetus and placenta and associated maternal tissues. So what happens if there is a reduced supply of nutrition to the pregnant women? It leads to various outcomes, particularly heightened risk of death among infants and children, and many times even women are not able to complete their term of pregnancies. And it has also been found in numerous studies that prenatal exposure to the nutritional deprivation has a long-term postnatal effect on the health outcomes, on the reproductive health outcomes, and finally on the muscle mass that the population has. And so therefore, it's very important to understand, this increased risk of infectious and communicable diseases that has a direct bearing with the higher rates of, neonatal mortality and infant mortality in several global south countries. So moving forward, if you look at how does the global dietary consumption looks like. So if you look at some of these recent data which are available today, this data by the Global Dietary Database Consortium, which has assessed the trends and patterns of dietary consumption in 187 countries from 1990 onwards to 2010, they basically say that there are basically two kinds of dietary patterns. One is of course healthy dietary pattern based on 10 different kinds of food, and then there is something called unhealthy dietary patterns at the population level based on different 7 categories of food consumption. But one thing is very clear, that globally consumption of healthy items has improved, there is no doubt about it. But at the same time, the consumption of unhealthy items has actually worsened in several low and middle income countries of Africa and Asia. Now, it's important point here I want to emphasize is that largely in the global south, in countries like in continents such as Africa and Asia, the standard of living of population is very modest, plus due to inflation, and the inflationary trend of course fluctuate over the years, but by and large because of these trends, what happens that it is far more easier, particularly for those who are residing in the urban centers of these global south, to purchase food which is cheaper and affordable, and most of them are not very nutritious, and thus that is categorized as unhealthy food, which has huge implication for chronic and lifestyle disease burdens. So looking at this diet and their trends, we observe that there is a lot of variation between countries at the global level, and there are also systematic variation in the different strata of society of any country. So largely we observe that people who belong to relatively higher socioeconomic status of the population, they have higher purchasing power to buy, for example, more vegetables, more fruits, more pulses, so more healthy foods. On the other hand, people who are from economically weaker section of society, the purchasing is a big problem. So many times various governments, for example, in the case of India, we have this public distribution system program since 1975 onwards. Now we also have this National Food Security Program since 2013 onwards, and during the COVID pandemic and afterwards, the government of India has been providing access to food for population more than 800 million. 80 crore population is being supplemented with food supply at different rates. In India, we also classify population at different socioeconomic groups. For example, households which are below poverty line, or may also be termed as Antodaya household. They are provided cheaper food grains as a very subsidized rate. The idea is to support the provision of nutrition to the population, and particularly for children and infants and pregnant women, the Anganwadi system is there, which takes care particularly of children and infants who are undernourished. And I'm sure that we all recognize this fact that despite tremendous record of economic growth in the country over the last 35 to 40 years, one of the basic issues that country is still struggling to answer is the sizable proportion of undernutrition among children in the country, and also the burden of anemia among women in the country. Still more than one third of the infant and children in the country are undernourished. Either they are stunted with regard to their age, or they have underweight, or they are facing wasting. Likewise, more than half of young women and adolescent girls do also suffer from nutritional deficiencies, which require very concerted effort from policy makers, and that can only come if there are evidences which are available at different geographic scale. So there is a huge opportunity for geographers and social scientists to help understand the problem in different contexts, and of course we cannot have one size fit policy for the entire country. So we need to be aware of various agroclimatic conditions, and accordingly, as they say that whatever is available in the area, in the geographic area, and whatever is seasonal is not only affordable but also highly nutritious. And so therefore there is a need to have nutritional literacy program. Why? Because if you look at some of the recent data from the National Family Health Survey, it shows that very alarming trend that not only do children from economically backward section of society, but even so-called wealthier or well-off households also, the prevalence of undernutrition is quite sizable, which is very alarming. So there are two kinds of issues that country is facing. One is, of course, that there are limited availability of food to the household because of the purchasing power parity or purchasing capacity of these households. At the same time, there is also issues of knowledge, because people have limited knowledge of what is healthy and what quantity of food should be consumed, at what interval to be consumed. So if there is programs at the school level, in education system, where we can educate our young kids to understand, adolescents and youth, about healthy food habits, that is extremely important. Because if you look at most of the government programs on nutrition and health, they talk about micronutrient deficiencies, they talk about health supplements, but rarely do they talk about how to eradicate the unhealthy dietary patterns in the population. Recently, the University Grants Commission, Government of India, has come out with a guideline to discourage the practice of consumption of unhealthy diet in the university and college campus, which is a very welcome effort. But again, if you look at schools and colleges and universities in the countries are so diverse that implementation of these novel ideas needs to be appropriately monitored. And we are very much concerned particularly about schools in the country, because most of the schools where we have our adolescents studying, you have access to all kinds of substance abuse, for example, different kinds of tobacco, gutka, pan masala in nearby campuses. So it's very important to have a concerted policies from the local administration, from education society, civil society. How can we discourage and reduce the practice of substance abuse among our youth, which is one of the biggest challenges that we are facing. Now moving on, if you understand the burden of disease which may be attributable to poor diet, there are some examples that I would like to discuss briefly. So if you look at the global level, it has been estimated that nearly 75% of all the deaths and close to 60% of all disability adjusted life years lost by 2020 is actually attributed to the burden of non-communicable diseases like cardiovascular disease, cancers, and type 2 diabetes. And many of them are actually related to the dietary patterns in low and middle income countries where these risks are highly clustered. So unhealthy dietary consumption is one of the major risk factors of the increased trends in the metabolic risk, the problem in metabolisms in global south. So for example, the issues of blood pressures or lipid glucose or body mass index, obesity, these are some of the biggest risk factors related to mortality and morbidity globally. And if you look at, for example, consumption of sodium, there is a high consumption of sodium which has been identified as one of the most important risk factors related to cardiovascular diseases, which is related to elevated blood pressures. And globally, it has been observed that more than 1.65 million annual deaths occur from cardiovascular causes, which are attributable to disproportionate consumption of sodium beyond WHO recommended levels. Further, if you look at the consumption of sugar and sweetened beverages, that also has implications on the adiposity and the weight gain among the population, and has been identified as important risk factor for cardiovascular diseases, diabetes and cancer. One of the studies which have been done has identified that consumption of these sugar and sweetened beverages on the burden of cardiovascular disease, and found that close to 184,000 deaths per year are occurring globally, which may be attributed to the consumption of these sugar and sweetened beverages. Further, it has also been seen that if you look at the types of dietary, fats that people are consuming, it's another important risk factor. Particularly, I'm talking about fats which is trans fats or saturated fats, which we call as bad fat. So, which is very important risk factor, and it has been estimated globally that more than 700,000 deaths per annum is attributable to the consumption of so-called bad fats or saturated fat. And so therefore it's very important for us as a society, as a health geographer, epidemiologist, to bring about behavioral change, and for which nutritional literacy is one of the major important opportunity. There was one study which was commissioned by the Ministry of Health and Family Welfare, Government of India, in collaboration with the Public Health Foundation and the IHME Washington, and they were basically looking at building a database to understand subnational burden of communicable disease in the country. And finding from this report has very compelling data for us as a scientist and for policymakers. Now, if you look at this data, we see that from 1990 onwards to 2016, there is a remarkable shift in the burden of disease in India, where the outstanding point is we are facing a tsunami of non-communicable diseases, and of course we have been able to curtail the infectious and communicable disease. So NCDs is a bigger challenge because of number of factors, whether it's lifestyle, whether it is behavior, or because of demographic transition. And if you look at the data which was presented in the report in 1990, predominantly all part of the country had the problem. Most gravitated in the empowered action group states, for example UP, Bihar, Rajasthan, Chhattisgarh, Madhya Pradesh, and several northeastern states. There has been a shift. The burden of now NCDs have increased, and communicable disease has come down. Among various risk factors of disability adjusted life year lost, there are one or two critical factors are of course dietary pattern, which is one of the important key factors of burden of disease, and hence there is a clear-cut indication from the study that the Government of India, various state governments and various stakeholders of development have to come together to address the issues of how can we encourage access and supply of nutritious food and dietary habits in the population. At the same time, how can we reduce the consumption of unhealthy diet and substance abuse, which is presenting a tremendous risk for our population. And so to conclude, I would like to highlight few points, that nutrition and dietary pattern are systematic in the population with the process of development which that is unfolding. There is a remarkable variation at the global level, as we have seen that in 1950s and 60s, particularly in the global south, there was predominantly infectious and communicable diseases. And if you look on the other hand, in the case of advanced societies, there are largely 80 to 90% burden of diseases are linked with infectious, communicable and chronic diseases. Now, if you look at these NCDs, among various factors which are responsible, dietary habits and consumption patterns is directly related. For example, we discussed about how the consumption of sodium beyond WHO recommended limits has implications on CVD burden of disease. Likewise, consumption of bad fat, which is saturated or trans fat, has implications on heightened risk of cardiovascular diseases. And we also looked at this framework to understand how the nutritional deprivation operates at various levels, from national to subnational to the household level, compounded by the environmental hazards. And so therefore it's very important for us as a state and a society to understand that these implications are intergenerational. And so therefore it's very critical to address the nutritional program not only as provision of micronutrient or health supplement, but also it's a comprehensive program wherein information, behavioral change program may play a very critical role to improve the nutritional patterns or nutritional status of the population, particularly infant, children and pregnant women. At the same time, we should also have we should come up with studies and recent evidences on how, whether it's youth, whether it is adolescent, what kind of dietary habits or knowledge they have about nutrition, because these are the youth, these are the young people who will be taking up the leadership in 20 years down the line. So if we are able to inculcate healthy food habits and nutritional literacy among the young people today, they will have important implications for generations to come. So thank you for your attention.